Hi, my name is Joy Dugan. I'm a physician assistant and clinical professor at Touro University. You are currently taking a class online, and we're in Module 3 of our diabetes intensive training. Module 3 already had a portion on diabetes pharmacology taught by Drs. Young and Drs. Wong. If you have not already taken that, please look through that module before attending this module on diabetes pharmacology cases, because we're going to apply real-world patients to the principles of pharmacology that you already learned in the lecture. So to start off with, we're going to review our module objectives, which are to recognize clinical situations where it would be appropriate to use more than one anti-diabetic agent, to describe indications, contraindications, and side effects for each class of diabetes oral medications, to summarize which diabetes medications are used to achieve goal postprandial or fasting glucose levels, and to compare treatment and management of diabetes in special populations, including chronic kidney disease, chronic liver disease, geriatric, pediatric, and pregnant patients. So our first patient is Shelley. She's a 45-year-old obese female. She's got a BMI of 45, and she has a significant family history of diabetes. Her mother, older sister, and maternal grandfather all have type 2 diabetes. She admits to a sedentary lifestyle and frequent fast food. She denies symptoms of hyperglycemia, including polyuria, polyphagia, and polydipsia. On routine labs, her A1C was 7.5, which is diagnostic of type 2 diabetes. Shelley, after receiving intensive lifestyle education, including exercise recommendations and offering to meet with nutritionists, she declined therapeutic lifestyle changes and wanted to start taking a medication. So after continuing to counsel her on the importance of a healthy lifestyle, we decided to start a medication on her. What medication do you think would be the most appropriate first-line medication? Think about it. So according to the American Academy of Clinical Endocrinologists, with an A1C under 7.5 like Shelley, we could start on monotherapy with any medication in this list. We should try to optimize her medication in this list within 3 months, meaning we want to get to her goal of under 7% within 3 months of starting the medication. And if we're not, then we're going to go to dual therapy. The medication that we would most likely start off with is metformin, and you can see it has a green line that's a little bit longer than the others, so it has the highest recommendation. So this is a hierarchy of recommended medications. Metformin is at the top because, number one, it's been used for years with great efficacy. It lowers the A1C approximately 1.5%. It's generally very tolerable, and it's also on the $4 list at Walmart. So most insurances are going to actually require you start this medication. So applying some of the principles that you learned in your lecture with Dr. Young and Dr. Wong, let's look at this study stack I designed for you. Now, study stack you can use to help quiz yourself. So for example, you'll press question, and it'll say, what class of drugs is metformin? You can click answer, and then it'll tell you it's a bigonide. So let's say we got that wrong. We'll click keep. So that way it'll go to the back of the pack. So now question, name 2 indications for metformin. Click answer, and then you'll get that it's type 2 diabetes, and polycystic ovarian syndrome is another indication for diabetes. So we got that right, so we're going to discard this. Next question is the mechanism of action of metformin. Well, let's say we got this one wrong, but just so you know, the answer is it does decrease hyperglycemia by inhibiting hepatic gluconeogenesis, and it also increases insulin sensitivity at the muscle level by activating AMP kinase. So we'll keep that one. So I'm just going to go through these And so you can see that they start to repeat themselves right here. What class of drugs is metformin, which was our first one, bigonides. So you can continue to play a game with this. There's other games too here that you may enjoy, such as Hangman. So what you're going to do first is I click show with a hint, so that way I can try to guess, because I'm not very good at Hangman. So individuals at risk of lactic acidosis, kidney, liver, lung, blank, and alcoholism. So you can type in DISE. So we know it's probably diseases. But let's click something wrong, and then you can see that it'll create your little hangman. So you can do this over and over again, and they'll come up with different principles related to metformin. There's also other matching games, or the hungry bug, that might help you to apply these principles. So going back to our Prezi, we're going to talk about our next case, which is Larry. He's a 68-year-old male with type 2 diabetes for 24 years and chronic kidney disease for the last 5 years. He is currently maximized on metformin 1,000 milligrams, one tablet twice daily, and glipizide 10 milligrams, one tablet twice daily. He denies polyuria, polydipsia, polyphagia, or hypoglycemic episodes. His current A1C is 7.2. His GFR, which is his kidney function, is now a 28. It's down from his last lab over 6 months ago, which was 45. So Larry is one of your long-term diabetic patients that's very motivated to keep his A1C down. He does not want to adhere to a less stringent goal, which may be appropriate in some patients with CKD. Since he has no hypoglycemic episodes, it'd be very appropriate to stop the metformin in this case and try a different medication. Now, the reason why we're going to stop metformin is because of the Food and Drug Administration 2016 guidelines. Basically, you should get a kidney function prior, or GFR, prior to starting metformin. If the GFR is normal to 45, you may start metformin. If the GFR is 45 to 30, it's recommended against starting metformin. But if the GFR was 45 to 30, and like in Larry's case, he's been on it long term, you could keep him on the metformin. Some may opt to reduce the metformin, although the research that's currently out is inconsistent. However, if the GFR is below 30, it's an absolute indication to stop your metformin. So in Larry's case, his GFR is a 28. We need to choose a different medication. So going back to the ACE, the American Academy of Clinical Endocrinologists, we have here the chart that helps us with our selection. So Larry has renal insufficiency, or CKD, so he's not going to take metformin. We have to be careful with GLP-1s. So exenatide is contraindicated with a creatinine clearance of less than 30. Exenatide is also known as Byetta. However, other medications, such as Victoza, have no renal dosing, so you may want to choose a different medication in the class that's not exenatide. SGLT2s are a newer class of medications. They are associated with an increase in yeast infections. I would recommend against using them in renal impairment. There's a box label that GFR less than 60 to avoid. I do really like using DPP-4s in type 2 diabetics. Just note that the most commonly prescribed one, which is Januvia, does need to be dose tapered, which means that if their GFR is normal to 50, they can be on the highest dose of 100 milligrams. If their GFR is 30 to 50, however, they should be on 50 milligrams of Januvia. If their GFR is below 30, they should be on 25 milligrams. I often choose to prescribe Tradjenta, which is a newer medication in the class, in patients with renal disorder because there is no dose tapering because it is not renally excreted. So it may be a good idea to consider that in your practice. I don't generally prescribe these other classes of medications, but just to note that TZDs may worsen fluid retention in CKD, so it may be a bad idea to give those. And then sulfonylureas, he's already on. I'm not going to stop the medication, but CKD does increase his risk of hypoglycemia. Larry denied having hypoglycemic symptoms, which is great. Glyburide is absolutely a contraindication. ACE and the American Diabetes Association both recommend against using glyburide because of its association with such high hypoglycemia, especially in elderly patients with renal failure. These two classes are not generally prescribed Clovisel and bromocriptine. Insulin, I don't think he's an appropriate candidate for insulin at this point. His A1C is 7.2, which for him is possibly within normal limits for him because of his age and renal impairment. So our next patient is Juanita. She is an 82-year-old female with type 2 diabetes for 30 years and CHF for the last 10 years. Her CHF began after she had a heart attack 10 years ago. She frequently experiences hypoglycemia symptoms 2 hours after eating her lunch. Her blood glucose levels have dropped to as low as 52. So the key thing here is that she is getting hypoglycemia, which is very dangerous. We want to avoid this at all costs because it increases an 82-year-old's risk of falling. So we want to probably avoid any of the classes of medication that cause hypoglycemia postprandially, because that is when she's getting her low sugars. So if we go to our study stack, I create another one that would be helpful for you, glucose matching. So what you can do here is you can match the class of medication with either fasting or postprandial, because each medication works more on a specific time of your blood sugar. For example, sulfonylureas work primarily on postprandial, so they would be inappropriate for Juanita. Other medications are like Novolog and Humalog. They work postprandial and would be inappropriate for her. However, things like metformin work on the fasting state, which would be a better choice. If she was on insulin, we would prefer a long-acting insulin initially because that works on her more fasting state. So you can complete the rest of these cards on your own at another time. So that's Juanita. Our next patient is Marie. Now, Marie is a 29-year-old female who just found out she's pregnant with her first child. Ideally, we want her very well controlled with an A1C under 6, according to the American Diabetes Association and the American Academy of Clinical Endocrinologists. She wasn't planning to get pregnant. She's very excited, though. Her A1C is 7.2 on metformin 1001 tablet twice daily. So we know we have to fix this problem immediately because not only are we dealing with mom, but we also have a baby on board that needs to be protected. Her blood sugar needs to come down reasonably. So she's already on metformin. Another option for oral medications would be glyburide, which is considered a pregnancy class B, which is safe in pregnancy. But that's not the gold standard. The gold standard is actually either Levemir or NPH insulin. So she should be on insulin. Our last case is Manny. He's a 34-year-old with type 2 diabetes diagnosed 3 years ago. He has difficulty maintaining a diet and exercise program. He's overweight, and he just doesn't enjoy these things. His A1C is currently 7.8 on metformin, 1,000 milligrams, 1 tablet twice daily, and glipizide 10 milligrams, 1 tablet twice daily. He's afraid of shots and doesn't want to start insulin. So what would we consider in him? So metformin he's maxed out on. The GLP-1 class of medications is also a shot. So we're not going to consider that. The two classes I would most consider for him is either an SGLT2 or a DPP-4 inhibitor. The reason is because SGLT2s are associated with weight loss, which would certainly help his diabetes, or DPP-4 inhibitor, which is weight neutral. He's already on a sulfonylurea, so we're not going to give him that. A TZD is associated with a lot of weight gain, so we may want to avoid that. AGIs, Colvazole, and Bromocriptine are not used very commonly in the United States and are relatively ineffective. So this is the resources that I used. Feel free to take a look at them. Thank you so much for attending. Please email me at joy.dugan@tu.edu if you have any questions.